Good afternoon, everyone. Thank you for joining us for a lunchtime webinar on colorectal cancer and the causes, risk, and prevention. Our speakers today are Corie Price and Richard Sheriff with West Georgia Gastroenterology. Corie Price is board certified by the American Academy of Nurse Practitioners. She earned her master's in nursing from the University of Alabama at Birmingham in 2014 and her bachelor's in nursing from the University of West Georgia in 2007. She has been working in GI with West Georgia Gastroenterology since 2015, and prior to that, she was in the ER as a nurse for 8 years. Richard Sheriff grew up in Hiram, Georgia, and attended the University of Georgia, where he met his wife, Kristen, who is also a nurse practitioner. Richard initially worked as a registered nurse at Tanner Medical Center, Carrollton, on the orthopedic surgery unit for 3 years before transferring to intensive care unit at the Tanner Villarica facility, while going back to school for his master's degree. After obtaining his nurse practitioner degree in 2019 from Columbus State University, Richard worked with Tanner Heart and Vascular Services for 3 years before moving to gastroenterology in the office setting. Richard and his wife live in Carrollton and enjoy attending community activities. They have a 3-year-old daughter and are expecting 2 more twin girls later this spring. Corie and Richard, I will turn it over to you and you can begin whenever you're ready.
Okay, thank you. Thank you for having us also. Can you hear me?
We can, yep.
Okay, very good. Okay, so how do I kind of go to the next page there? Very good. Okay, so what is colon cancer? So colon cancer is cancer that forms in your colon, which is your large bowel. And it's typically from polyps. So polyps are little growths. They can be hyperplastic, meaning that there's nothing really bad about them. They never would have really turned to cancer. And then that goes all the way to adenomatous, and then they kind of get worse from there. And polyps are really important because it gives us an indication of how often people need to be checked. So if you have large polyps, multiple polyps, precancerous polyps, it helps us determine when you need to be scoped again to avoid cancer in the future. Also, the age of the patient is important. If you have a 25-year-old with several large polyps, that's kind of a big deal versus if the patient is 68 and has one small hyperplastic polyp. We know that they're probably going to fare pretty well. So it just gives us an idea of how often to check you. Okay. I think we're good on that one. What causes colon cancer? So unfortunately, there's not just one thing that you can avoid and you be good to go. With colon cancer, there's several things, diet, which we'll talk more about later, smoking, alcohol use. They've defined it here as males is 15 or more drinks per week, and women is 8 or more drinks per week can increase your chances of colon cancer. Also, you can have a genetic predisposition for colon cancer. So, if your mom and your sister have it, your chances are a little higher than general population. Okay. Okay.
Hey guys,
we're good there.
I'm going to take over on this slide here. So this talks a little bit more about who is at risk for colon cancer, higher risk than just the average individual. Like Corie mentioned, there's several different factors. The first one we have here is simply age. Your risk for colon cancer certainly increases as you grow older. That's why we don't recommend starting general screening until you're 45 years old. And finding colon cancer does increase as you get older. So that's why we want you to start at 45. And then will be every 10 years of screening colonoscopy after that if everything is unremarkable. Some other factors can be ethnicity. We do know that the rate of colon cancer is higher among African Americans. So another good reason to get screened if you are of African American heritage. Diet, our American diets do tend to be high in processed foods, processed meats, sausages, hot dogs, red meat, beef. We eat quite a bit of that, which does also increase our risk of colorectal cancer. Family history, we do know that colon cancer can be hereditary. If you have history of a mom, dad, brother, sister, grandparents who have had colon cancer, you definitely want to be screened and keep up with that as recommended by your gastroenterology provider. Going a little further into the family history, some people with a very strong family history, multiple relatives, we do recommend for genetic testing, which we can talk more about at your appointment. Like Corie mentioned, there are some genetic conditions called Lynch syndrome, which make you at a much higher risk for colon cancer. And those individuals that have tested positive for Lynch syndrome would have more frequent colonoscopies every year or two. People that have inflammatory bowel disease conditions such as Crohn's or ulcerative colitis, you may have heard of, are also at increased risk for colon cancer, and they are generally screened with a colonoscopy more often as well. We can go to the next slide. So in general, there are some signs and symptoms to look out for, but I want to make it very clear that you could have no symptoms at all with colon cancer. So another reason to get screened before you have any problems for preventive measures. But some things definitely that are red flags would be noticing bright red blood when you have a bowel movement, or black stool also is bad. Jet black tarry stool is another reason you need to come and see us. Stomach pain, aches, cramps that don't just go away, after a day or two, something that's not just, you picked up a viral GI bug at a restaurant or something, but things that just go on for no reason. If you're losing weight for no apparent reason, we need to get that worked up. Weakness or fatigue that just seems to be going on for no other reason. If you're having urgency to have a bowel movement, but you've already had a bowel movement and you know that you're empty, but you still feel the need to have a bowel movement, that can be a red flag. Feeling that you don't empty all the way completely after you have a bowel movement. Also, a decreased appetite, that's not your normal, is something to look out for. Constipation or diarrhea that goes on more than just a few days here and there, but something that becomes more of a chronic condition. Certainly you need to talk to a gastroenterologist. And then again, at the bottom, just a reminder that you could have very vague symptoms or no symptoms at all. Something to remember there as well. And then again, I did make a note that weakness or fatigue is a sign of anemia, which we do see with colorectal cancer. So another reason to get screened. Okay, we can go to the next slide. And Corie, if you want to pick up on this one, or I can take it.
Sure. So screening. So essentially, screening is really checked. A lot of people really don't like that. They feel like if they're doing okay, there's no reason to check anything. But that's kind of the time you do want to check, because early cancers, you really don't have a lot of symptoms. And specifically with your colon, like he was saying, you can feel really good, not have any symptoms, and have a little cancer brewing in there. So screening is preventative. We're trying to kind of catch things before they're a problem. Do a colonoscopy, remove polyps that maybe aren't a problem right now, but are likely to turn into a problem. So that's really important. Screening in regards to your colon, forever it was age 50, but because people are getting cancer younger, they have bumped it down in the last year or two to 45, which is important. And then this part here is just saying, you might need to get checked a little earlier than 45 if you're having problems. So if you're 30 and you're bleeding and you have diarrhea and your belly hurts real bad, you're going to get a colonoscopy. You're going to get checked out. Inflammatory bowel disease, which is Crohn's or ulcerative colitis, not to be confused with IBS. They are completely different. People with IBD, Crohn's or ulcerative colitis, are at a higher risk of cancer, unfortunately. So we check them pretty regularly. One, to check their disease state, also because they can get cancer. So we just got to keep a really good eye on them. Also, personal or family history of polyps or cancer. If you've had them before, it's something that can happen again. So we keep a closer eye on those folks. Also, again, genetic predisposition. There's lots of different types of, the Lynch syndrome, familial polyposis. There's several different little things that can put you at a little predisposition. Okay. And you can go on to the next one there. So importance of screening. Colon cancer is super common. So like we were saying, you want to get to the problem before it's really, really bad, and potentially remove polyps and all before they become cancer. Age is the #1 risk factor. So if you are 45 and you've never been checked for colon cancer, you absolutely need to consider it. It's real important. Lifestyle factors, being overweight, smoking, etc., that can put you at a higher chance of having colon cancer. And again, family history, mom and sister have it, your likelihood is pretty high. So you need to get checked sooner and probably more often than the general population. Okay.
And we can start picking up right here. So I'm going to talk about the actual test to screen for colon cancer. Colonoscopy, and then there are some other diagnostic tests that we'll discuss. If we can flip to the next screen. So colonoscopy is the gold standard. There is not a replacement for a colonoscopy. It's highly recommended as the screening modality for colon cancer. If for some reason the patient absolutely refuses to have a colonoscopy, there are some other options, although they're not quite as good. So let's talk about a colonoscopy. This is a procedure that's done as an outpatient. You'll come and talk to us in the office. We'll get everything set up, talk to you about the prep the day before, and put in orders. Once you get scheduled, you'll have a prep that you do for 24 hours before the test. The day before the test, you'll be on a clear liquid diet, things like chicken broth, beef broth, Kool-Aid, Jello. You can have, and you will drink a solution that is basically a laxative to clear out your colon. The doctor wants to be able to see the lining of your colon tissue. We don't want any stool inside there because they won't be able to see that part of the colon. So you do have to be cleared out to have an accurate colonoscopy. The procedure itself just involves you coming in to the clinic or outpatient center or the hospital, either one, wherever you get scheduled for. You'll get into a gown. They do start a little IV. Nurse anesthetist will give you some medicine through that IV to put you to sleep for about 15 or 20 minutes. And the doctor has a thin scope, tube-like instrument that you can see in this picture here that has a bright light and a camera on it. It also has a little hole where they can put tiny little tools through to snare polyps if they need to remove those while they're in there. And they can look through your entire colon to make sure everything looks normal. If they see polyps, they will typically go ahead and remove those while they're in there. And then basically, if everything is unremarkable, there are no polyps and you don't have family history, then you only need one of these every 10 years. If they do see some polyps, then we'll have a discussion afterwards to determine if you need to have one more often, 5 years or so. But that'll just depend on the findings. You need to take off work the day of the procedure for sure. They don't want you driving or doing anything too strenuous afterwards because you have been had some anesthesia. The next day, you're totally back to normal, whatever you need to do the next day. And we can flip to the next slide there. Now, if there is some reason that you just cannot have a colonoscopy, there are a couple of tests. One is called a fecal immunochemical test or a FIT test. This is done annually. It's a stool test where you get a little stool sample on a card and you bring it back, and it looks for blood in your stool, specifically blood from the lower intestine or the large colon. Now, if that test is positive, then you really need a colonoscopy afterwards. And that test would be done annually. There is a Cologuard that you've probably heard of, seen commercials on TV for. It is a stool test also that you send in a box through the mail, and it actually tests for blood as well as some DNA molecules that can be from colorectal cancer. or a large polyp. There is a pretty high risk of false positives on the Cologuard. If you have a positive Cologuard, you definitely need a colonoscopy. We do get a lot of patients come in that have done a Cologuard and it's positive, and then we set them up for colonoscopy afterwards. I did look up some statistics on this. So there are a lot of false positives. Out of the false positives, about 45% of them are nothing or just a benign polyp, 4% are cancer, 20% are an advanced adenoma polyp, and 31% are regular adenoma polyp. So again, these tests are not a substitute for colonoscopy, only for people that just, for whatever reason, cannot have a colonoscopy. These would be better than doing nothing at all. All right. We'll go to the next page there.
So colon cancer is being diagnosed in younger ages. Like I mentioned earlier, so much so that they've actually decreased the screening age. We're routinely checking people younger. Insurance companies have to pay to let you get checked sooner because it's just so common now. Nobody really knows why exactly. Again, obesity, diet, smoking, drinking, physical inactivity, family history, you can have a genetic predisposition. Also, apparently, gut bacteria, anything that alters your gut microbiome can cause, diarrhea, weird gas, belly pains. Also, it looks like possibly cancer as well. So you can have, some predispositions with those things. But the screening age is now 45 for general population. Okay. And colorectal occurrence. So this chart, it's essentially showing you cases versus deaths in 2020 for colon cancer. And I'm not going to bore you by reading it all, but 65 and up is obviously the most. But as you can see, 0 to 49, it's quite a few. And I don't really know why it's getting worse and worse. Apparently, environmental factors, et cetera, are playing a part. But per the American Cancer Society, between 1995 and 2019, the percentage under age 55, it was like 11% back in 1995. 11% of people would get colon cancer. And then 2019, it was like 20%. So it just kind of crept up over the years. It's almost doubled. And again, it's environmental factors, et cetera. Okay.
I'm going to talk a little bit about this slide, preventive measures, things you can do to reduce your chances of colorectal cancer. Regular colorectal cancer screenings are definitely necessary. Other than that, a well-balanced diet. Fiber, we have learned, is your friend. Fiber is found in fruits and vegetables, whole grains. There are the high fiber cereals, Fiber One, Cheerios, All Brand, those types of things. Fiber acts as kind of a bulking agent to make bulkier, softer stools that don't spend as long in your colon. So think about it as like less time for toxins and things like that to be exposed to the colon tissue, which is a benefit. Also reducing the bad foods that we know can contribute to your risk of colon cancer, like red meats and fatty foods, in moderation with those. Regular exercise, as with all of your other body systems, is definitely beneficial. The goal from the American College of Cardiology is 30 minutes of regular exercise or walking 5 days per week, something to work towards. Avoid smoking, sure, no tobacco or excessive alcohol consumption. We know that smoking and excessive alcohol consumption can increase your risk of colon cancer as well. And these things kind of all go in line with your other general care maintenance issues. You should have a primary care provider that kind of keeps a general overview of your whole health situation. Things like for men, having prostate checks, prostate blood tests as scheduled, women with their yearly mammograms, all that stuff is important to keep in mind in general. And I think that pretty much wraps it up. If anyone has questions, Corie and myself are available to answer those.
That was awesome, guys. If anyone has questions, please type them in the chat box and they can answer them. I will go ahead and ask a few to give people some time to ask some questions. I know the thought of a colonoscopy scares a lot of people, and that's why they just don't do it. How long does the actual procedure take?
The procedure is 15 to 20 minutes, so pretty quick.
Okay, so they're in and out pretty fast.
Yes, it's very quick. So if you've ever had a procedure where you've been under for several hours and you wake up and you feel like you've been on the moon and you just, you feel very, very strange for a while, it's really not that bad. I've actually had a colonoscopy. I'm not quite screening age yet, but I had a really bad colitis a few years ago, and I had to have a colonoscopy to check it and make sure everything was healed and normal. And in my experience, it was very easy to me. I've had some very painful procedures, and that's outside of kids, et cetera. And to me, it was nothing. It's not fun. Nobody really wants to do it, but it just sort of is what it is. You do the prep, bowels move, you go to sleep, you wake up, you go up there, you're asleep the whole time for the procedure. And then you can go to Cracker Barrel when you leave. Like it's very easy, I thought.
And are colonoscopies covered by insurance?
Yes and no. So most every insurance I've seen, maybe there's some strange plans out there. Most every regular plan will pay 100% for a screening, meaning you have no pain, no problems. It's time to check for cancer. If you are 45 and you come in for your screening and you've been pooping blood for 6 weeks, it is not a screening. It's diagnostic. You're having a problem. So that's the other thing, where it can get very sticky with insurance. I'll just leave it at that. But insurance will cover it to some point, even if it is diagnostic, depending on deductibles, et cetera. But for a screening, like we've been talking about today, typically, yes, it will be covered. Sometimes patients do get a bill, but it'd be from the lab. Your procedure is covered, the hospital, like everything is covered at 100%. But you might get a lab fee if you had polyps that they've sent to the lab.
Okay. And you guys talked about the other tests, such as the Cologuard and the other one. Is that something that a primary care doctor can order for a patient, or does it have to be from a gastro physician?
No, that is something they can order. But I'll tell you, I have a little bit of beef with those tests because, well, for one thing, like he was saying, there's a lot of false positives, which always makes me wary of false negatives. And the other thing about those tests, there's lots of tests. There's colonography, where it's like a fancy picture. There is a blood test. They're just, none of them are great. And anything but a colonoscopy is a 2-step test, meaning if it's positive, now you've got another step. Now you need a colonoscopy. So, I'm just not really big on those. My other problem with them is, like you were asking, can they order them? Absolutely. Anybody can order it. But like, I had a patient the other week that came in for a positive Cologuard, and he had a mother with colon cancer, and he had bad diarrhea. He didn't have any business doing that test because he has problems. He needs a scope. It needs to be looked at. So those tests are for people with no pain, no problems, no family history, no history of polyps, completely normal. Then it's okay to do them.
Okay. We did have a question come through the chat box. Recommendations for someone age 70 with history, non-cancerous polyps, and family history, and their last colonoscopy was 5 years ago.
Okay, so now that all depends. Now, the size of the polyp can matter, and how many polyps. Typically 3 or more polyps, that would be a 5-year, would be pretty good for that. If one or any of them was larger than 10 millimeter or 1 centimeter, probably needs to be looked at. Also the family history, we go by 1 first degree, specifically if that first degree was under age 60, or 2 second degrees, specifically if they're under age 60. So if we're talking your great-great-grandma's cousin, probably not that big of a deal, versus if it's closer family members who are younger, yes, absolutely, the 5-year mark would be good. So it just kind of depends a little bit depending on the exact biopsy. Now, let's say you have a patient that just moved here from Michigan. They don't have their records. They know they have they had some polyps. They're not really sure. You know, we're not really sure on the exact biopsy. Probably safer to just check it.
Great. I'm going to give just a minute or so to see if anyone else submits any questions.
Sure.
All right. It looks like that's all the questions we'll get. Thank you so much, Corie and Richard, for your time. Thank you all for joining us for this lunchtime webinar. Please continue to check out Tanner.org for future classes and events, and we will see y'all later.
Awesome. Thank you.
Thank you.
Thanks. Bye.